So the LOXO-305 is the third generation BTK inhibitor. The first generation BTK inhibitor is ibrutinib. It is a covalent irreversible BTK inhibitor, binds to the C4081 amino acid position pocket. The second generation is thought to be more specific, but it is also in the same category with ibrutinib and the acalabrutinib and the newbrutinib. They are both similar with ibrutinib in terms of covalent irreversible BTK inhibitors. And so the third generation is represented by LOXO-305. In contrast with the first two generations, which were covalent irreversible, the LOXO, the third generation, is non-covalent BTK binding, and it is reversible. So the properties of covalent irreversible versus non-covalent reversible is very difficult to see which one is better. There are theories on both things, both are good, but the only test is do clinical trials to see which one would have more efficacy, more durability, less toxicity. So the third generation, this is the first in-human clinical trial that is both phase 1 and phase 2. In phase 1's clinical trial has major 4 cohort, the SL-CLL cohort, which will be presented by my colleague, Dr. Anthony Mato, at the upcoming ASH 2020 on the CLL-SL part. But I will present the others, including mantle cell lymphoma, Waldenstrom's macroglobulinemia, the Richter's transformation, follicular lymphoma, marginal zone lymphoma, and also large cell lymphoma. So that my part is everything except the CLL. So first of all, we found no DLTs. The drug is so well tolerated. So no DLTs, there's basically lack of grade 3 or grade 4 toxicities. And the toxicities are, fatigue. It's the toxicities that typically rash, bleeding, cardiac arrhythmia, arthralgia, fatigue. Those are the side effects are rarely present. Those side effects are permanent in the first 2 generations of BTK inhibitors, but it is less likely, almost some of them absent from the current clinical trial. So, so the MTD is chosen artificially at 200 milligram daily. So this is orally daily drug given every 28 days as a cycle. And so the LOXO-305, no DLTs, therefore we chosen artificially MTD at 200 milligram daily orally. So this is chosen based on the area under curve, the Cmax, but also we believe that if we choose anything above it, although there's no DLTs, but we think is likely that anything above 200, 250, 300 would still be tolerated well, but it has a risk of hitting the off-site kinases. And potentially in the long run, in the larger pool of patients with a long treated over a longer period of time would probably have more side effect. So in order to avoid that, we choose 200. We think that's adequate in terms of area under curve of drug exposure. So among the 56 patient with a mantle cell relapsed mantle cell lymphoma after 3 prior lines, the response rate is 52%. Please remember, the first 2 generations of BTK inhibitor, if the patient is resistant to one, it will not respond to the another BTK inhibitor, both including first two generations. In other words, if it's ibrutinib resistance, acalabrutinib, then ibrutinib is not going to work, and vice versa. Okay, so but in the LOXO-305 population, the majority of patients has received first one or two generations. That means, why the first one, two generations, they cannot overcome resistance from each other? Because they bind to the same pocket of C481 position. But we believe that LOXO-305 attacks a different epitope of the same enzyme. Therefore, even the patient has mutated C481, even the patient has resistant with or without mutations to the first two generations, LOXO-301 still has the same response of 52% after 3 prior lines of therapy. And if we study LOXO at early lines or without BTK prior engagement, we believe the response rate might be even higher. But 52% in a BTK resistant population is very good efficacy data, especially with basically lack of severe side effects. And so we think LOXO is a superb drug in relapsed mantle cell lymphoma. And but what about in Waldenstrom's? In Waldenstrom's, after 3 prior lines of therapy, regardless of pre or post BTK, the response rate is 68% after 3 prior lines. This is very, very impressive data in Waldenstrom's relapse after 3 prior lines. In patients with Richter's transformation, the response is 75%. Follicular lymphoma, 50%. Marginal lymphoma, 25%, and large cell lymphoma, 24%. So please remember, the large cell lymphoma is after 4 prior lines of therapy. 4 prior lines of therapy is still 24%. It's as a 5th line, that's very, very impressive. So follicular lymphoma, 3 to 4 prior line therapy, marginal zone lymphoma, 4 prior line therapy, the response rate is also very significant. And a phase 2 clinical trial for pivotal trial in mantle cell lymphoma is being planned, and also that for large cell lymphoma is also being planned. So the shortcoming of this presentation of this data is that the follow-up time is relatively short. It's only 6 months. But I believe, as an investigator who has treated patients longer than that period of time, my experience has been that even with a longer duration of follow-up, the responses are still very durable.